Okay, welcome to the fourth and final video on diabetes. So help me God. Today is going to be all about therapeutics for type 1 and type 2, and it'll be the last time I talk about this fucking disease for hopefully ever. Diabetes mellitus is one of the leading causes of death in the United States, and the common complications that result in death are myocardial infarction and end-stage renal failure. And as a reminder, it is also one of the leading causes of blindness and non-traumatic lower limb amputations and just general cardiovascular disease. And the prognosis of these patients primarily depends on glycemic control, and as well as the management and treatment of comorbidities like hypertension and dyslipidemia. So basically what I'm saying is exactly what I've always been saying, that the best treatment for diabetes is to keep that HbA1c levels below target. And that brings us to the goals of diabetic treatment, right? So the goals are both to achieve and maintain normal or near normal glycemic control wherever possible and appropriate, as well as preventing diabetic emergencies like DKA and HHS, and then to prevent symptoms, and that'll be things like the osmotic symptoms and the recurrent infections, as well as the fatigue. Diabetes treatment is also kind of aimed at modifying risk factors, specifically cardiovascular risk factors like smoking or sedentary lifestyle or increased body habitus, and other comorbid risks like hypertension, dyslipidemia. So remember, we love giving diabetic patients ACE inhibitors because it both controls for hypertension and it has that renal protective effect. The target HbA1c for diabetes is 7%, and that is a bit higher than the normal HbA1c, but an HbA1c of below 7% is associated with drastic reductions in risks and complications. All right, so how do we get people to that target level? Let's start with type 1 diabetes. So type 1 diabetes is absolute insulin deficiency, so our big treatment is we give them insulin. Insulin is our most powerful glucose-lowering agent. It's safe, it's effective, and it is well tolerated. Now, there are new basal insulins called Toujeo and Tresiba, and these are longer-acting concentrated formulations, right, that combine the various insulins. And these tend to lead to less hypoglycemia, and they have a little bit more flexibility around the timing of the dose. So patients don't have to be quite as attentive to their calibrations, but insulin is not a perfect drug and it does have side effects. The first and most dangerous side effect is hypoglycemia. If a patient miscalculates or takes their insulin and then doesn't get to eat, they can end up in a hypoglycemic crisis, and this can be life-threatening. And another side effect, or like shitty thing, is weight gain, right? Insulin suppresses the breakdown of fat, and if you're not breaking down fat, you're gaining weight. In therapeutics, there are basically 5 types of insulin: rapid-acting, short-acting, intermediate, long-acting, and ultra-long-acting. Rapid-acting is basically the kind that you take right before meals. It has a 15-minute onset, and it peaks at about 1 hour, and it lasts for about 3 to 4 hours. And this is drugs like Aspart, Lisro, or Glulisine. I hate drug names. And this is important because this is the kind of insulin you use when you're treating patients in HHS or DKA, right? Because it's quick and it's dirty. It does its job. Then we have short-acting, which we conveniently just call insulin. And this is great because it can be injected subcutaneously like, all the insulins, but it can also be used in an IV. It's the only insulin that can be used in an IV drip. So this is the insulin we use when we're treating hyperkalemia, which is going to be a totally different video if I ever talk about it at all. The onset for short-acting is about 30 minutes, so you do actually need to do some stuff while you let it kick in, right? Especially in emergency treatments. But again, not going down that rabbit hole. And it basically peaks at 2 to 3 hours, and then it only lasts for about 5 to 8 hours. Intermediate insulin, also called NPH, it lasts for about 16 to 24 hours, but it peaks at around 4 hours. And then we have our crazy long-acting and our ultra long-acting. Sorry, I shouldn't have said crazy because that's confusing. It's called long-acting, and then the other one is literally called ultra long-acting. I guess because we just didn't expect that we would make an insulin that lasted longer, and we didn't leave anything in our naming convention for that. So long-acting and ultra long-acting are actually really interesting because they have no peak of action. And ultra long-acting ones like Degludec and Tresiba last with a duration of 48 hours. So, that's great. Now, it's important to understand that patients will be on some sort of combination of, a basal insulin that they're taking that is longer acting, and then, a rapid or short acting insulin that they inject prior to meals. And it can be a really complicated, calibration and math, and they have to be really attentive, and they have to pay a lot of attention, which can be really, really difficult, particularly if, you're a 14-year-old kid. So, it's not the world's most fun thing, but it is effective, and it's reasonably cheap if you're not in America, and it does its job. The other thing that's really important is that there is no such thing as oral insulin. All insulins are injectables, and that's because the stomach acid would destroy the insulin before you could actually use it. And that means that all of the insulins come with the same suite of complications that any injectable would. Plus, there's a fun bonus there of the social stigma, right? And remember, a majority of type 1 diabetic patients present in childhood. So like I was saying, having appropriate and good education for them to allow for appropriate adherence to this regimen of stabbing themselves with needles a couple of times a day can be really frustrating and really difficult. And the final thing to be concerned about with insulin is driving implications. So driving implications only apply to insulin and sulfonylureas, which I will talk about later, but what it means is you need to tell your insurance company if you are taking insulin. And if your HbA1c is under 5%, you cannot drive. You need to check your glucose levels before driving, as well as every 2 hours for continuous driving. And if you are in an accident and you haven't checked your blood glucose levels, your insurance company will leave you high and dry and you will get boned. Also, if you have more than one severe hypoglycemic event, you can no longer drive, which blows. Okay, and hypoglycemic events, which I will explain because I'm remembering that these videos are supposed to be for people who don't know anything. I'm good, I promise. So hypoglycemia is exactly what it sounds like. It's low blood sugar, and most patients are aware of the fact of when they're entering a hypoglycemic state because they are able to recognize the symptoms. However, some patients will not, or will have never experienced it before and won't catch it until it gets more severe. And so your typical symptoms are things like tremor, sweating, irritability, dizziness, pallor, pretty much anything you associate with being really fucking hungry. So you may have even experienced a minor hypoglycemic event yourself. However, more severe hypoglycemic events are going to be altered or reduced consciousness, and then coma, and then death if they are not treated. And the treatment for this is you basically give them sugar. You want to give them a combination of a rapid-acting glucose, so that's like a Lucozade or an orange juice, and then something that has slower-acting carbohydrates, so, biscuits or toast, for when the rapid-acting glucose inevitably burns up. Options for treating the really severe hypoglycemic events are going to be IV dextrose, right? We're going to go immediately in with IV, and then we're going to give them intramuscular glucagon. And remember, glucagon is the spiritual opposite of insulin, and what it does is it increases blood glucose levels. So basically, you want to make sure as a type 1 patient that you are carefully calibrating your insulin therapy to prevent both hyper and hypoglycemia. And I could go into the millions of calculations of how insulin is given and how we calculate insulin therapy, but here is the thing, I really want to be done with diabetes at some point, and that kind of stuff is really ultimately very patient dependent. Also, there is new technology coming out about this all the time, and it's nuts. Hand to God, we're 4 years away from a fully autonomous electric pancreas. I mean, they're already combining little blood glucose testers with insulin pumps. We're there. Technology is magical, y'all. Anyway, instead of talking about that, and not at all because I want to procrastinate on type 2 therapeutics, I'm going to talk about some funky and weird complications, which are the Somogyi effect and the dawn phenomenon. And basically, both of these are a form of early morning hyperglycemia with just a bit of a difference in why. So, dawn phenomenon is not actually an uncommon problem in type 1 diabetics. It's functionally early morning hyperglycemia as a result of the physiological increase of growth hormone levels in the early morning hours, which stimulates hepatic gluconeogenesis. Basically, your body releases growth hormone because it wants you to grow, and this causes your liver to make/release sugar with the intention of having it be used for fuel for that growing process. But since you're a type 1 diabetic and you don't actually make insulin, there's this mismatch between now there's this a lot more sugar and there's not enough insulin, right? So the insulin demand can't be met, which results in these elevated blood sugar levels in the early morning hours. So our basic treatment for that is first you measure nocturnal blood glucose levels because you want to be sure about what's happening. And you'll see why later when I talk about the Somogyi effect. But you measure the nocturnal blood glucose levels, you identify that it is in fact the dawn phenomenon, and then you have a couple of different things you can do. So you can consider giving them potentially a bolus of longer acting insulin at 11 p.m. Or you can make other modifications to their glycemic control. And then with children in particular, you could also consider an insulin pump that'll be able to supply insulin throughout the night. So the other effect we're going to talk about is the Somogyi effect, which is pretty rare, actually. And it's early morning hyperglycemia, just like in the dawn phenomenon, but it's caused because of a counter-regulatory secretion of hormones. And that secretion is actually triggered by nocturnal hypoglycemia, secondary to an evening insulin injection. So, in plain terms, what occurs is you take your insulin dose as usual at night, right before you go to bed, and your body actually ends up dipping into hypoglycemia as you sleep. And then your body panics because it doesn't want to be hypoglycemic. And it dumps out a ton of hormones. So it dumps out glucagon, and it dumps out epinephrine, and it dumps out cortisol, and it dumps out growth hormone as a compensation. And then what happens is your blood sugar levels actually shoot up. And then you have high levels. So you wake up with hyperglycemia, but it's because you dipped into hypoglycemia in the middle of the night. So the treatment for this is you actually lower these patients' nightly dose of insulin, which you can see now why it would be really, really important to figure out whether or not a patient is undergoing dawn phenomenon or the Somogyi effect, because they literally have opposite treatments. If you lowered the insulin dose for a patient who's doing dawn phenomenon, you're going to kill them. But if you raise the insulin dose for a patient who has the Somogyi effect, you're going to kill them. So you need to make sure that you know what's actually happening. Okay, last thing about insulin, and then I promise to do type 2 therapeutics, even though I don't wanna. So patients' insulin demands can change. So if you have a patient coming in for surgery, they actually do need a dose adjustment, right? There is an element of variability associated with physiological stress. So they're gonna need more frequent monitoring, and they might need sorry, that guy was so loud. Don't worry about it. Just recognize that insulin doses need to be adjusted. So if you have a patient who's in the ICU or is being admitted to the hospital and they are a type 1 patient, you need to be also mindful of what their insulin dose is and whether or not it needs to be changed. And the final thing that does bear mentioning is that there is a form of eating disorder for these patients that is referred to as insulin purging, right? And that is an attempt to lose weight by purposely not injecting themselves with insulin after a meal, right? This is a form of an eating disorder. And this is extremely dangerous, both in the short term, but it also increases their risks for long-term complications. So you have to be worried both acutely about hyperglycemic coma and then, also long-term. And these patients need both support and psychological intervention. And on that super cheery note, let's start talking about all the confusing type 2 stuff. There are like a million drugs for type 2, and it's confusing, and I'm going to do my best. I'm sorry in advance. We're going to start with our big heavy hitter, our frontline drug, metfucking-formin. Don't say metfucking-formin when you're ordering for these drugs. Just say metformin. That should be self-explanatory, but you never know. It's a biguanide, and its buddy drug, which is called fenformin, is no longer used because it used to have super high risks associated with lactic acidosis. And metformin does still have that risk, but it's way lower. And again, we love metformin. And why shouldn't we? It's a great drug. It reduces microvascular risks, right? It reduces cardiovascular disease risk. It reduces the risk of neoplasm. It lowers the serum free fatty acid concentration. It promotes weight loss, which we really love to see in type 2 patients, right? It works, which is important. And it's also important how it works, which is it works by increasing insulin sensitivity in the body, as well as decreasing liver production of glucose. And it's considered to be weight neutral, which is great, which just means that we don't have to modify the dose or the intake based on the patient's weight. So, metformin, it's safe, it's effective, and important to the machinery of healthcare, it's also cheap. And its most commonly reported side effects are not fun, but relatively mild, which are just gastrointestinal distress, right? Nausea, bloating, flatulence, diarrhea. Not enjoyable, but definitely better than dying. Now, of course, there are real considerations to take in, right? The considerations for metformin are basically as follows. One, it does increase the patient's risk of contrast nephropathy, which basically means you've increased the risk of giving these patients kidney damage while you're doing imaging. And this is very important to be mindful of because diabetic patients have, we've talked about this in complications. You don't want to mess with their kidneys. Their kidneys are under enough strain as it is. So metformin needs to be held for about 48 hours before any IV contrast is given. I don't know why I ended that sentence like there was going to be more there. That's the end of the sentence. And like I mentioned before, metformin does increase your risk of lactic acidosis. So it's really important to assess these patients because they are diabetic patients. And you need to make sure that they have good renal function before you give them metformin because otherwise they're going to end up in a lactic acidosis crisis and you are going to have a bad time. So our second line drugs are sulfonylureas, and our most commonly used one is gliclazide. And sulfonylureas work by closing the ATP-sensitive potassium channel in the pancreas, and that basically ultimately leads to an increase in insulin secretion. If that didn't really make sense to you, don't really worry about it. Just understand that sulfonylureas increase the endogenous production of insulin. They make you make more insulin. So obviously these drugs are not at all useful for type 1 patients, right? Or for anyone who can't make endogenous insulin for any reason. So as patients progress in type 2, you need to be mindful of the wear and tear on their pancreas, right? Because if their pancreas isn't working, neither will the sulfonylurea. And you might be thinking to yourself, wait, this is great. Like, this is a great drug. It makes you make more insulin. That's what we want. But no, there are side effects. So some of the notable side effects for sulfonylureas is weight gain, which is particularly bad in type 2 diabetic patients, right? And then these are associated with increased risk of hypoglycemia. And specifically sulfonylureas, when they're used as monotherapies, and this is why they're not first-line drugs, is they increase the risk of cardiovascular disease and myocardial infarction, which was already not, you were already at increased risk because you were a diabetic patient. So that is why sulfonylureas are never used as monotherapies, and they're not first-line drugs. They can also cause pancreatic burnout, and that's basically where they accelerate the destruction of the beta cells, right? And that's because what they are doing is they're stimulating them into overproducing insulin, and that puts a lot of strain on this beta cells and on the pancreas in general. Okay, and the next two drugs we're going to talk about are GLP-1 analogs and DPP-4 inhibitors, and both of those work with the incretin pathways. So incretins are hormones produced by the GI tract, and basically what they do is they work by increasing insulin secretion, inhibiting glucagon production, and they slow absorption in the GI tract. And the main incretin that we give a shit about is called glucagon-like peptide 1, or GLP-1. And GLP-1 is a gut hormone that is secreted by L cells in the intestines in response to nutrients. And GLP-1 analogs basically stimulate insulin release in a glucose-dependent fashion, right? Which is awesome, which is great, because it means that they're responding to the level of sugar in your blood. And we love anything that means that we have to do less math. So our GLP-1 analogs are a ton of things, and I'm about to just fucking lose it on the names, but we're going to try. So we have liraglutide, right? And that's, once daily. And then we have exenatide or exenatide XR, which are weekly. And then we have, dulaglutide or Trulicity, which is the trade name. And then we have semaglutide, and those are both weeklies. And what we need to remember is they are inherently responsive to the amount of glucose in the body, so they don't need to be titrated doses in the same way as insulin. Also, bonus fun fact, because I think it's really fucking cool, exenatide, which is the only one of these GLP-1 analogs that doesn't have glutide in the name, it's based on this peptide called exidin-4, which we derived from the saliva of the Gia monster. How fucking cool is that? We also have liraglutide, which we did by, modifying human glucagon, peptide 1. Which is significantly less cool, but also good, I guess. So GLP-1 analogs work like incretin, right? So they boost the function of insulin in the body, and they also inhibit glucagon in the postprandial or the post-meal setting, which allows them to control for hyperglycemia also in that way. And finally, they delay gastric emptying and also reduce appetite through central satiety effects, right? They go into your brain and they make you feel full. And that leads to weight loss, right? They go all the way up into the hypothalamus and they're like, you're done. And you're like, okay, shit, I guess I am. And then there's like a second bonus also. They have a potentially protective effect on the beta cells of the pancreas. And you might be thinking, Yara, shit, this is amazing. These GLP-1 thingies are dope as hell. Why are we not treating everyone with these? And I will tell you why, my young Padawan. It's because, one, they're kind of new, and we're scared of any new drug in medicine. Which, honestly, we have good reason for, so, like, let us have that. And then, two, they're kind of expensive, which, sucks. And then 3, they're injectables, right? Like with insulin, you can't actually take them orally, you have to inject them, and that's its own pile of annoying. And finally, of course, the dreaded side effects. So the most common side effects associated with GLP-1 analogs are nausea and vomiting, but they are also associated with pancreatitis and pancreatic cancer. Do not ask me how they are both associated with the protective effect of the pancreas and also with damaging the pancreas. This is why we don't like new drugs. It's because we don't understand what they're doing. The good news is a recent meta-analysis in JAMA, which is, one of my favorite medical journals ever, showed that GLP-1 mimetics are associated with a reduction in all-cause mortality, which, hooray, especially as compared to DPP-4 inhibitors, which were not. So that's a big win for GLP-1s. Speaking of DPP-4 inhibitors, what the hell are those? Let's talk about them. So those are our gliptins, right? Those are, oh boy, come on. Those are stigagliptin, sacagliptin, linagliptin, vildagliptin. Basically, it's a drug name that ends with the word gliptin. And these also work through the incretin pathway to provide a modest reduction in HbA1c, and basically they work to increase levels of circulating GLP-1. Sorry, I almost forgot to say 1 there, and I tacked it on the end. This is a real smooth recording. So these drugs are very well tolerated. They're weight neutral. They carry a low risk of hypoglycemia, right? Because they're, they work in the incretin pathway, so they're responsive to the amount of sugar that's already there, and then they stop. And they have a low GI side effect profile as compared to GLP-1 analogs. And on top of that, they can be combined with metformin. So all of that's great. However, there is that JAMA paper that I just talked about, which showed that they aren't as effective as GLP-1s, as well as the fact that they have some not super awesome side effects. So, DPP-4 inhibitors are associated with nasopharyngitis and peripheral edema, and these drugs are like fine for glycemic control, but they're not actually that great. And you also can see symptoms of upper respiratory tract infections, and of course, you are at risk for pancreatitis now. So, they're newer and they have some pros and cons, but like I said before, they don't seem to have the efficacy as some of the other therapeutics, as well as they don't have as much research behind them, so you don't really see them in use as much. Okay, our final type 2 diabetic drug that we're going to talk about is SGLT2 inhibitors, or our leflozins. Dapagliflozin, empagliflozin, canagliflozin. And the way that these drugs work is they actually inhibit the reabsorption of filtered glucose in the proximal renal tubule, right? So they stop the kidneys from picking sugar back up out of the urine. So they induce glycosuria, which basically means that they lower your blood sugar levels by having you pee out all your glucose. And this is great because it can cause a decrease both in blood pressure and in weight, and it has a low risk of hypoglycemia. Also, if you've been paying attention, you might find this a funny treatment because what we basically do is we take a side effect of having diabetes, which is having glucosuria, and we're like, hey, you know what? What if we use that to treat you? So yeah, they cause a decrease in blood pressure, they can help you with weight management, they have a low risk of giving you a hypoglycemic crisis, plus all of these effects are independent of insulin, and you can just take this medication at any point during the day. And there is some emerging evidence that they may have a cardiovascular risk reduction element and a renal protective element, which is great. So, empagliflozin has been shown to reduce the risk of cardiovascular disease, reduce hospitalizations with heart failure, and all-cause mortality in type 2 diabetes. And that was the EMPA-REG study. And then canagliflozin has been shown to reduce the risk of cardiovascular events such as MI, stroke, and death, as well as hospitalizations with heart failure in type 2 diabetes patients, and that was the CANVAS trial. And these reduced risks are pretty likely related to the fact that they are SGLT2 inhibitors, but there isn't enough evidence yet to say that this is because of the class of the drug rather than just the individual medications. So it hasn't technically been proven to be true for all SGLT2 inhibitors. And that is why empagliflozin is your most commonly prescribed SGL2 inhibitor, right? Because it's the one that has the most research behind it. But they're not perfect drugs, which makes sense because the perfect drug literally doesn't exist. They're associated with increased UTI and candidiasis, which makes sense because there's a ton of sugar in your urine, and that's a situation where UTIs and candidiasis thrive. And finally, they rely on renal function, so they're completely ineffective with a GFR of less than 60. And so the GFR is the glomerular filtration rate, and it's basically a measure of whether or not your kidney is doing its job. And because these drugs rely on kidney function to filter the sugar into the urine in the first place, as the kidneys begin to fail, these drugs stop being effective. And the last thing about SGL2 inhibitors is that patients on SGL2 inhibitors become at risk for diabetic ketoacidosis. And that's why I said before that DKA isn't exclusively associated with type 1, even though it is much, much more common in type 1. And that's because patients on SGL2 inhibitors are at risk for DKA. It's rare, but it does happen. And finally, as we talk about therapeutics, type 2 diabetes patients can end up on insulin, right? We try to avoid this for as long as possible, but all these other therapeutics, except for obviously SGL2 inhibitors, rely on the fact that the patient is still producing endogenous insulin. If for some reason this stops being true, all of those drugs stop working. So monitor your type 2 patients. Make sure they're fucking okay. Are there other drugs in diabetic therapeutics that I didn't mention? Fucking probably. There are so many goddamn drugs out there, and we also keep inventing new ones, which is super fucking frustrating. And I'm also sure that this video will be super outdated in 5 years, but hey, those were your big ones. And for type 2, I cannot say it enough. Metformin is our industry standard and it's our darling. We know how it works, we know that it works, and it's cheap and it's easy. So pretty much every single patient is going to start on metformin. And then you'll do all of your weird calibrations and your weird calculations from there based on patient tolerance and individual need. Okay, thank you for coming. Therapeutics, fucking done. Diabetes, fucking done. Join us next time for a video on anything but diabetes. I'm excited.